Okay, I think we're going to get underway here because we're 3:45, and that's what time we're supposed to start our talk. My name is Dr. Paul Sobey, and my colleague and myself, Elizabeth Loudon, are going to be presenting on recovery-oriented systems of care, implementation in correctional settings, and we're also going to talk a little more broadly about the Alberta model and the work we're doing in Alberta, and we're going to talk about some of the lessons we've learned and future directions. So that's what we're going to talk about today, and very pleased to be here. So disclosures, number one, disclosures. The primary disclosure that Elizabeth and I have is that we are, I am an owner and I work for a company called ROSC Solutions Group, which is a healthcare company that provides services through grants to the Alberta government. And other governments. So that's our primary disclosure, is that we are going to be talking about work that we are doing from a company basis and disclosing that directly up front. It may result in further work for us, and I certainly hope that it does. What are we going to be talking about today, and what are our learning objectives? Well, number one, I want to talk to you about therapeutic community model and the history and the evidence, because it's a model that I'm very excited about. I want to talk, Elizabeth is going to speak about staff selection and how did we effectively launch and maintain the therapeutic living unit, TLU, environment. TLU is the acronym we use for therapeutic communities in jails, and to provide maximal benefit to its members. And then how do we do things like selecting members, and what does the daily program look like, and case management, and all of that kind of integral stuff, all of that kind of granular stuff. We're going to talk about that. And then Elizabeth is going to speak to the continuum of care, the other work that's going on, because we can't just have one isolated intervention in jails to treat addiction. There has to be a continuum of care. So we're going to talk about some of the other work that we're doing in the context of the Alberta model, and we'll finish with key points, and we'll have a few pictures throughout our talk, because I'm a bit of an amateur photographer, so you've got to have some pictures. I always start with this slide to frame up who we're dealing with, and I think that this is a really important slide to kind of frame up the correctional population. We know that more than 70% of inmates in provincial correctional facilities have a substance use disorder, and regardless of what the DSM says, these people are recurrently losing control over their substance use. They have major compulsion to use substances, and they experience consequences recurrently and then continue to use the substances. That's severe. 72% of inmates, and this is a BC stat, with substance use disorders and mental health disorders will be reincarcerated at 3 years. And so this is the kind of stat that we look at, is 1 year 35%, 2 year 50%, 3 years more than 70% of people are reincarcerated. Something's not working. A statistic that I was really blown away by was a study done by Biswanger in she looked at data between 1999 and 2003 on the overdose death risk of inmates discharged from Oregon or Washington State correctional institutions in the first 2 weeks. It was 129-fold that of the general population. The overdose death risk has risen 5-fold since then. So what we're looking at is a population that has an overdose death risk of up to 600-fold the general population. 20% of all the costs of substance misuse in Canada, $10 billion, are attributable to criminal costs. But 28.5% are healthcare, and 42.5% are lost productivity. There's a reason why we're in corrections, and the reason why we're in corrections is because we have a cohort there that is readily available. This cohort is not being offered appropriate treatment. A general principle in medicine is treatment matching. The treatment must match the severity of the disease. If I have a early lung cancer, I'm offered very aggressive radiotherapy, surgery, chemotherapy, etc. I'm not offered cough syrup. In corrections, the vast majority of people are not offered treatment that is commensurate to the severity of their disease. Substance use disorders is the primary cause of criminal and medical recidivism in this population. And the evidence clearly demonstrates that if you treat that, if you treat substance use disorders in this population, that is the most effective way of reducing recidivism. Criminally, we know that by the evidence, and then by extension, we would assume that that's also true for medical recidivism. We know through some studies that therapeutic living units, high dose, long-term treatment of substance use disorders in criminal populations, inmate populations, can reduce medical and criminal recidivism, can reduce the likelihood of being reincarcerated by up to 50% in the first year. That's really cost effective. And then the last piece is that the research around cost effectiveness demonstrates that, guess what? Treatment is highly cost effective. These are high consumers. These are consumers. We're spending about $341 a day average to keep an individual in jail. That individual will come back 35% in the first year, 50 in the second, up to 70 plus in the third year. That was wasted money. That $341 per day was wasted money. So what is therapeutic community? Where did this term come from? It's not new. We are not doing anything new in this model. What we've done is we've modified the model for a correctional facility. It was around in Great Britain in the early 1900s as the original sort of democratic psychiatric model. In the late 50s, it was founded through self-help movements as and termed the therapeutic community. Growing community of recovery-seeking peers developed this unique residential treatment model that had a different way of viewing the disorder and a different way of viewing the person. The therapeutic community was termed that in the 1960s, and it spread throughout the United States and Europe in the 1970s. So there was quite a movement. You know, it's kind of like, I don't know, it's kind of like the continental philosophy movement before rationalism came along and it disappeared. What about the history of TCs in jails? 1970s. In the 1970s, there was early recognition, and this is 50 years ago, people began to recognize an association between substance misuse and crime. So we've known that for 50 years, that there's an association between substance misuse and people committing criminal behaviors. We also, at that time, started to know that there was an association between a lack of access to social determinants of health. It wasn't called social determinants of health at that time, but it was conceptualized around that time that if individuals didn't have access to those social determinants of health, like there was early trauma, there wasn't access to good mental and physical health care, there wasn't access to housing, occupation, etc., that there was an association with crime. In the early 1970s, it was also noticed that there was possible cost savings with this model. And it was known at that time that habilitation for individuals that had never had the opportunity to experience rehabilitation, and social reintegration were all possible. And so this movement of TCs into jails, primarily by Phoenix Society in the United States and other nonprofits in Europe, TC made its way into jails. So things are moving along. TC is demonstrating reasonably good outcomes, both in community and in jails, but for some reason it really disappears around 2000. And why? And this is not clearly articulated in the literature. It's really sort of me looking and talking and reading. And what I've really found is that as the American model and other models became more health maintenance organization or pejoratively managed money, the funder looked at therapeutic communities, long-term, high-dose treatment and said, outpatient treatment works just as well for this particular sample. The sample was generalized to all people, and there was a movement toward outpatient treatment. And then there was a movement, of course, toward defunding outpatient treatment. So inpatient to outpatient treatment because of financial issues. The second one was there was a movement toward more pharmacological and psychiatric-based treatments. This was at a time when Alan Leshner, the CEO of NIDA, declared, I think it was in 1994, the decade of the brain, neuroimaging, et cetera. The cure for addiction is just around the corner, and there was a movement toward a more medicalized approach of addiction. And it was difficult to prove the outcomes within the evolving evidence-based model that TC was doing, and a lot of those were social outcomes. How do you calculate the cost of an individual that does not go back to a criminal lifestyle, but instead rejoins their family? Their children, his sons and daughters, don't engage in substance misuse, they get jobs, they become productive members of society. It's difficult, those metrics, and ascertaining those costs was very difficult at this time, but we now have the ability to ascertain those metrics. And the evolving polydrug epidemic. 50,000 people, nearly 50,000 people have passed away in Canada since 2018, around 500,000 in the United States in that same time period, and now there's renewed interest in this model. How does the TC view substance use disorders? Well, it's distinctly different than the medical model. What TC does is it doesn't view the person based on their substance use. It's not you're a heroin addict or you're a methamphetamine addicted person. It's a whole person approach. And really, the way we've modified TC for jails is the key approach is social determinants of health. We look at the individual as a whole, we look at their behaviors, and we look at their social determinants of health. And the model is predicated on addressing the gaps in social determinants of health. That's really, and there's a medical piece to it too. We don't manage the medical piece in jails, but there's lots of people that are using OAT and other psychiatric medications, and that's part and parcel of what the treatment is. But the core approach to TC is addressing social determinants of health. So what I'm going to do now is I'm going to briefly review the literature on TC. I'm going to do it real quick. So these first three slides talk about substance use and crime and treatment versus punishment. And this is from 2023. So we've known for a very long time in this article that the evidence clearly supports treatment for reducing criminal recidivism and medical recidivism, as is evidenced by substance use. So this article looked at 23 studies from 1971 to 2022, and clearly came to the conclusion that punishment does not reduce criminal or medical recidivism. And it didn't say it in this study, but it may also result in criminogenic effects. Earlier studies, this one by Sung, came to the same conclusion, that there is really no evidence that a punishment deters criminal behavior or the consequences of criminal behavior. Talking about correctional treatment effectiveness, this study, now moving on to treatment effectiveness and type of treatment. So this early study looked at papers from 1968 to 1996, and it was a meta-analysis, so a good framework, and came to the conclusion that although limited data was available, methadone maintenance, substance abuse education, 12-step and cognitive behavioral therapy showed potential for reducing criminal recidivism. So this paper was from 1999, and we knew as early as 1999 that these interventions could reduce criminal recidivism. This study looking at does incarceration-based drug treatment reduce recidivism, and also a meta-analytic framework looking at 66 evaluations from 2007 found, and looking at TCs, looking at RSAT, residential substance use treatment, group counseling, drug-specific boot camps, and narcotic maintenance, as in OAT, came to an interesting conclusion that there was consistent support for therapeutic community, but once again, these studies don't define what's the intensity of the program, what's going on in the day, how long is a person in the program, these variable pieces, but they did find that there was consistent evidence that TC reduced recidivism and drug use, but there was mixed results for the other programs with no support for boot camp. And boot camp's really popular in jails. Elizabeth and I have toured every single jail in Alberta. And a number of the jails have boot camps, and I look at it and I think, these individuals, these men and women that are in boot camps, they're really motivated, it's highly structured, they're doing exercise, and when they're released from jail, there's no reduction in criminal recidivism, there's no reduction in medical recidivism. So I look at it and I go, these are really inmates doing exercise, is really what it comes down to. That, I don't want to discount it though, because if you think novelly, that would be a really good pre-treatment program for TC. That would be an excellent pre-treatment program. We have a wait list. This would be a really good pre-treatment program for individuals, and we've seen individuals come into the therapeutic living units from boot camps, and they're much better prepared. Another study looking at the effectiveness of TCs, a systematic review from 2011, and only found 12 studies, but a good number of participants, 3,200, once again found that substance use decreased during TC programs, which we would hope, with completion as the strongest predictor. So once again, there's a problem with the literature. What defines completion? And we've very strictly defined completion so that we've got a starting point. But what defined completion in this literature? How long was the program? What did the program look like? But here's the key finding in this paper is that psychiatric comorbidities had no significant impact on outcomes. Now, that doesn't make any sense to me. But this is what we found, is that 80% of people in jail, or more than 70%, have a substance use disorder which is most likely severe. The general population, the comorbidity of other psychiatric disorders is far greater than 50%. In jails, it's probably 80%. When we do admissions, we see substantial other diagnoses. The validity of those diagnoses, I don't know. They may be highly valid. They may have had a comprehensive psychiatric assessment. The individual may have been told and given a label under inappropriate circumstances that they have bipolar disorder. But I'll tell you what I do know, doing medical practice for as long as I have, is that a pharmacological intervention by itself has limited impact. A pharmacological intervention with robust psychological, social, and recovery-oriented interventions has robust outcomes. And that's what occurs in the TC. And so my understanding, or my take on that finding, is that the program in the TC is so intensive and so laden with evidence-based psychological interventions that regardless of that pre-existing diagnosis, all individuals benefited. The tide raised all boats. Effectiveness of therapeutic communities for substance use disorders, now systematic review since 2000, but only 11 studies because the number of TCs in existence was contracting. Once again, what we find, and the slides cut off a little bit, is TC showed reduced substance use and criminal activity and improved mental health. There was variable outcomes once again, and the investigators recommended further research because of the variability in the data. Interventions to reduce harms due to drug use among incarcerated populations, and this study from 2024 and published in The Lancet, so really reputable journal. The background, indicates that people who are incarcerated have multiple issues, including mortality, suicide, self-harm, and substance misuse. They looked at 126 studies. So by this time, by 2024, there's a lot of literature to look at. And what are the findings? Well, of course, they found that OAT reduced death reduced mortality while the individual was incarcerated. This is true. It reduces mortality after the individual is discharged, provided there's ongoing use of OAT, but they also found, of course, that therapeutic communities, and the slide got cut off, I'm sorry, also reduced criminal and medical recidivism. So clear evidence of benefit. Looking at, once again, program type. So this study from 2012 again looks at 74 evaluations, and they look at TC, group counseling, boot camps, and OAT. Consistent evidence for benefit of TC, but what they also find is group counseling, which one-on-one and group counseling is the primary intervention for substance misuse in correctional facilities. Reduced offending, but not drug use. If drug use is not reduced, then, and my impression is that eventually there's going to be reoffending and there's going to be medical consequences, medical recidivism due to drug use, especially in the current opiate epidemic. Narcotic maintenance, OAT, reduced drug use, but not offending. Boot camps showed no significant effect, and I'm sorry, the slide's cut off, but TC demonstrated reduced criminal and medical recidivism. Cost effectiveness. So a couple of slides on cost effectiveness, because this is really what governments are interested in. One of the, I don't want to pigeonhole it like that. It's a primary issue that governments are interested in. What's the cost? What's the outcomes? So there's a couple of slides here that, number one, looked at the Amity program in California and aftercare, clear cost effectiveness, that looked at Delaware's CREST outreach program, clearly cost effective, but this is the real kind of study that I like to look at, is Connecticut's program, which demonstrated, which looked at two different arms. They looked at tiers of treatment, so intensity of treatment, and they looked at duration, 6, 12, and 18 months. What did they find? They found that there was a clear association between intensity of treatment and reduction in cost. So TC, therapeutic community, modified for jail-based environment, called therapeutic living unit, TLC, is a high-dose, long-term treatment modality. The higher the dose, the longer the term, the better the outcomes, right? Because we're treating people with the most advanced substance use disorders, as evidenced by their lack of access to social determinants of health. How much did it reduce costs? $1.8 to $5.7 for every dollar invested. That was $21,000 to $37,000. So highly cost effective. Talk a little bit about early outcomes in the Alberta model. We have some data. Next year when I come to CSAM, I'm going to have a granular and intense data. We've instituted a new EMR and modified it and structured it so that it automatically collects data for us. So 206 people. This is data from, let's call it at the end of October. We've had 206 people go through our programs. We have 4 programs, 4 therapeutic living units. The first one in Red Deer opened up on July 2023. The next one in Lethbridge, October 2023. The next one in Fort Saskatchewan opened up in February of 2024. I don't know if you've ever been up in Fort Sask in February. Wouldn't recommend it. And then the last one opened up at Calgary just recently, 6 months ago. Okay, so we've opened up 4 therapeutic living units over the last 16 months. And we've had 206 people go through, so there's still a lot of people in the programs. 43 people have completed so far, and completion is defined as the individual completes their sentence, or they complete their earliest release date, as in they're released, but they have intensive case management and warm handoff, okay? So that's a completion. There's a high bar for completion. 43 completers. Every one of those has a warm handoff. What's a warm handoff? A warm handoff means when that guy or that woman walks out the front door of the correctional facility, there's somebody waiting for him. That individual doesn't have the opportunity to go left or go right. Somebody's waiting, and not only is somebody waiting, like for weeks in advance, that's being organized that this individual from this treatment setting or somebody is going to pick you up and transport you directly to the next step in treatment. So of those people, about half of them, 21, moved into a recovery community, one of the therapeutic communities. 3 of 11 are built in Alberta thus far, have moved to those long-term treatment facilities. 13 were transferred about 25% to other treatment facilities, and 8 returned to live with their family. But every one of them had very strong case management. So the people that went to live with their family, they're connected to a recovery coach. They're connected to services in the community. We're doing aftercare with those people. Bit of a busy slide, but if you look at this slide, what it talks about is the number of days people have remained in treatment. Now, if you look at 75 to 99 days, about 51% of the population thus far has been in treatment for 75 to 99 days. And recognize also that it's early days. If you look at the people that have been in treatment for 250 to 274 days, those are predominantly going to be people from Red Deer that opened up in July 2023. So why is there a significant number of people that only made it 0 to 24 days in treatment? Well, there's a number of different reasons. This is early learning for us. Several of these people got bail, and they were precipitously discharged. But case management starts day one, because we're thinking you might get bail. So case management starts on day one. So we're still able to do reasonable case management and get a warm handoff even for an individual that's precipitously released on bail. We can't predict that, but what we're doing is we're doing education with the judiciary, with judges, taking every opportunity possible to speak to judges and speak to Crown and speak to defense about long-term high-dose treatment, and don't have the expectation that there's going to be any change unless this individual is in our program for at least 99 days. The other thing that might happen there is the individual may be diverting a medication like Suboxone or Methadone, and then they're removed from the unit back to general population for safety of the unit. We're working with AHS to ensure that there's better mouth checks, there's better nursing protocols. And then as time goes on, those early discharges are markedly reduced. Of the 206 individuals, about 54% have completed. So these are people that completed their sentence, or they made it to earliest discharge date, but had strong case management and warm handoff. Now, 30% are behavioral discharge. So this might be individuals that broke what's called a cardinal rule in the TLC. They made threats of violence. They made, they put the community at risk, and they were removed to general population. We follow up with every one of those people, and we're recouping about a third of them. So about a third of people that get early discharge back to general population, we're recouping those people back into treatment. And then 15% are voluntarily discharged. This slide speaks to social determinants of health. If you look in the upper left of the slide, the vast majority of people are unemployed when they come into the TLU. This needs to be addressed. This is why we talk about social rehabilitation, occupational rehabilitation. This is our focus at our large therapeutic community west of Gunn is what kind of occupational opportunities can we offer individuals that are going there? And our primary objective is to train individuals to work within this system. Another novel program that we're working on is building tiny houses. And, little houses, and big market for it. But occupational rehabilitation is clearly required. Bottom left, 41% of people have no relationship. Top right talks positively. 25% of people that are in TLUs are women, but women only make up to about 10% of the population in Alberta jails. So different unit, there's much more of a focus on psychological interventions in that unit than in the male units. And then in the bottom right, the age distribution really reflects the distribution of people that are in jail. The majority of individuals are less than 45 years old. The vast majority are less than 45. We do get several men in our units that are in their 50s and one of them in their 60s. And these individuals kind of go two ways. One, they don't fit in, or two, they become leader characters. Interesting slide. Methamphetamine is a drug of choice. Methamphetamine is the #1 declared drug of choice. 87 out of 206 people declare methamphetamine to be their drug of choice. Is there bias selection here? Is methamphetamine dependence more likely to result in criminogenic behaviors? Maybe so. Do we have a bias selection going on? Not sure. It's certainly my experience, though, that methamphetamine is becoming a much more commonly used drug, especially in northern Alberta and northern Saskatchewan and north throughout Canada, especially P2P methamphetamine, which has hugely deleterious effects on cognitive capacity and brain functioning. But I'm 100% convinced that the vast majority of those individuals can recoup brain function, but it requires long-term abstinence from substances and a cognitively rigorous environment, which is therapeutic community. ACE scores, adverse childhood events, average 5.4. So we know that an ACE score of 4 is associated with marked increased likelihood of substance use disorder and other negative mental and physical outcomes. Average score is 5.4, but the mean is probably significantly higher than that. And a bit of I kept on asking our IT people, like, how can you make this slide a little more readable? This is the ARC, the Assessment of Recovery Capital. So the assessment, recovery capital, as we know, is what an individual comes to the table with to initiate a recovery attempt. We measure ARC right when people come into jail, and we actually measure it on the day you were admitted to jail. So it's a retrospective ARC, but many of our people are admitted on like day 2 or 3 into jail. And the flip side of ARC, it measures recovery capital. The flip side is really social determinants of health. They align quite accurately. They map onto each other. So the average ARC on admission is 18.72. It's a very low ARC. 335% increase. It triples on discharge. What does that mean? Well, does it mean that the therapeutic community itself was the primary mediator of elevating the ARC? At this juncture, I don't really know what the answer to that is. Let me just see the slide. Yeah. So all measures in all domains of the 10 domains of the ARC rise. So what I was really hoping in using ARC is that there would be positive predictive value in it, in that we could look at the ARC from various different TLUs that had a little bit of different approaches, and this one was particularly beneficial in addressing this domain of ARC. And then also, what does a a particular domain in ARC predict for occurring? Does it predict for occurring for reduced criminal recidivism, reduced medical recidivism? Does it predict for increased likelihood of getting a job, etc.? But you know, the early results we have on ARC are that confluently all ARC scores tend to rise. Now that picture, I'll just briefly say a couple of words about this picture. This is a painting done by a fellow in the Calgary Correctional Center and our TLU there. When this guy came in, he's an incredibly talented guy, this guy. He plays guitar, all kinds of different genre on the guitar. He's a painter, an artist. He makes music. When he came in, he was frightened. The majority of individuals in jail, it's not terribly therapeutic. It's an anti-therapeutic environment. They're frightened. You have to be on guard. You don't sleep terribly well. It's a very hierarchical, negative environment. He got comfortable. And after a couple of months of being in the TLU, he asked through our staff if he could do a painting. And he was amazed when he could actually paint on the wall, because normally when you paint on the wall, you get institutionally charged for it. And he would make jokes about this. He completed this painting. This is about a 8-foot by 6-foot painting on a wall, and huge amount of symbolism in it. Each star is representative of one of the members and one of the correctional service workers, and there's all kinds of different symbolism in the painting. Huge amount of work went into it, and you know, I look at it when I'm sitting in the group room, and I look across the hallway at the painting, and it brings me a huge amount of aesthetic enjoyment. My last slide, critical incidents. So in the light blue, a 66 is a violence incident. And so what'll happen is you'll hear a code 66 to unit whatever, and we're instructed, you put your back against the wall, you stay out of the way, identify where the code is occurring, don't go near it, and the TAC team comes in. These guys, pretty darn quick, these guys dressed in like armor come in, and they may extract, break up a fight, or not uncommonly, there's 5 guys in a cell, one of them's getting beat, and one is holding the door shut, and they bust the door open and they pull those guys out and break up the fight. The occupation that is most likely to lodge a WCP claim is correctional peace officer, correctional guard. When that occurs, what happens is they get harmed physically and they get harmed psychologically. A lot of CPOs are traumatized by these events. It is incredibly costly to maintain a TAC team. It is incredibly costly. WCB claims are incredibly costly, and it has a hugely negative effect on the work environment. Code 66s in something like Edmonton Remand Center, Canada's largest jail, 1,600 inmates, there'll be 20 Code 66s a day. Down in Red Deer with 200 or so inmates, there's going to be 7 or 10 a week Code 66s. So since July 24, when we opened up Red Deer, we've had a sum total of 1 Code 66 across every TLU. A single Code 66. Medical or health incident, Code 99, also very, very common. We've had 2, and they were both chest pain that turned out to be anxiety. So I look at that, and I see 2 things. I see markedly improved workplace satisfaction for correctional service workers and correctional peace officers. And corrections is measuring this currently, and it's clearly obvious that people like coming to work. But also I see a huge amount of cost savings, and I see a very definitive change in the milieu where there's no violence. It's therapeutic. So I'm going to turn it over to my colleague, Elizabeth Loudon. Elizabeth?
Thanks, Paul. Hi, everyone. Thank you, Paul, for that. I always like to say Paul kind of gives all the data, and then I get to kind of stand up here and do the fun work and talk about how and why we do this. So as Paul said, we've been pretty darn busy over the last year and a half. We have opened up 4 physical treatment centers and jails, TLUs. And so we started, of course, with the Red Deer location. That was in July, as Paul said. A couple months later, we opened up Lethbridge. These are lovely places to live in Alberta, I just want to say. Paul took my joke about Fort Saskatchewan in the wintertime. It's a real nice place to live. We opened that one up in February, and then our last one is Calgary. On top of that, though, in the last probably 6 months, we've opened up 5 locations for what are called transition services. Transition services are individuals working within remand centers doing some of the case management work that we've kind of been known for. And so they're meeting inmates right in remand, assessing their social determinants of health, assessing kind of the deficits, and attempting to make some plans with them before they are released. And so being sometimes to be using making a quick plan because we know somebody's leaving tomorrow, and we don't really believe in the concept of somebody being released to a homeless shelter, released to a bus station, or just walk out the doors with nothing there to capture them. We want somebody to be able to know where the navigation center is in town. We want somebody to know how to get ID or how to know where to get a meal kind of stuff. We hope to get them into treatment. And that's, of course, our primary goal is to get these guys all into good treatment. But if we can't do that, we're going to do our best to just make sure that they are in a safe place. All right. I love these ones because these are some of the pictures of one of our treatment centers in jail. So this is Red Deer. And so if you notice, I don't know how many people have been to a correctional center before. Okay. So Red Deer is in a remand center. This is actually a decommissioned youth ward or youth unit. And we were able to turn this unit into a TLU. It still has cells. But we were able to, as you notice, bring comfortable furniture in. We were able to put rugs down. We were able to put posters on the walls. And as you notice, the quote-unquote bubble, which is the large desk, which the CSD or the correctional peace officer usually sits behind like a guard like this, doesn't have glass on it. It's very interactional. There's a classroom that they go to learn in or do group therapy in. We want to show the pieces of this, as I always I joke about the concept of TLUs are treatment centers in jails, but we try to make them feel less jaily. When an inmate walks in and they become a member and they see that picture or they see the furniture, and if you notice behind that black furniture is those horrible correctional chairs, those plastic chairs. In every other unit, that's the sum total of the furniture that's in there. They get these plastic correctional chairs. They do what's called dead time. They watch a lot of television sitting in those chairs. But they come in and they're like, you guys have comfortable furniture here? And it seems like such a thing that we all take for granted. We get to go home, drive our cars, take a bus, whatever it may be, sit on a couch, hopefully at home, and we enjoy our comfort. And these guys are blown away the fact that we can get a comfortable couch in there. Needless to say, those couches weigh about 67 pounds. They're really hard to lift. You can't throw them. They're very specific on the way that they're developed. But this gives you an idea of kind of some of our original TLU that we first kind of opened up. Oh, I think there it is. That we first opened up. So when we first started this whole project, Paul and I met with Haig and De Leon. Haig and De Leon are two of the founders of the TC model in Europe. They've written books on this. And we said, what do we need to do to be successful? How do we do this? Paul has worked in jails. He's seen kind of all the effects of substance use disorder. I have a long history working in treatment centers. And we said, how do we do this? And, they said, build community. And that was pretty much the sum total of the advice they gave us. And so we took that really seriously and we did our best to build community. And that community starts with staff selection. And staff selection, whether it be from corrections, we worked really hard to help them and kind of help them make decisions on who would be working on the units. And so, we encourage different interview questions. So making sure these people that are going to be on the units are going to be somebody that is going to want to engage with the member, not just police them, not just guard them, but actually have interactions. show a human side of themselves, be part of the groups that we run. And so we had very specific kind of lines of questions as we interviewed people for these roles. We also wanted these roles to be something that they wanted to be a part of. So not a voluntold, hey, you're going to work on Unit 3 today, but actually like, hey, I get to go to work in the TLU today. That's so cool. Oh my God, I wonder how John's doing. Like, those are the conversations we get to have today. But we met with them and like helped them find these people. Because these people, as we talked about community, corrections is a community. Sometimes it's not the healthiest community, I want to say that. And sometimes, people that choose to go work in programs like a TLU, they get called things like con lovers. It's my favorite. They get said, oh, you work in the airy-fairy program because we talk about feelings. And these guys also needed to be able to know, like, hey, it was okay that they were coming to work in the TLU and to be able to kind of stand tall and kind of go, yep, I do actually want these people to get well. I want to support them. Yep, you bet. We do talk about feelings there. But we wanted to build that community and have the people and the CSWs and CPOs that really wanted to be invested into that with us. So we hired a bunch of CSW staff, we helped them with it, and we brought our two groups together for training. For RSG staff or BCC staff, what we looked for primarily was, people, of course, that knew treatment, but we looked for people in recovery. And so, we want our members to be able to benefit, to be able to kind of look at these people that are helping them. We call them behavioral health navigators. That's what a counselor is called on the TLU. We wanted them to look at their behavioral health navigator as somebody that had something to offer them. And not just a new clinical skill. I'll tell you about all the clinical, kind of different things that we do on the TLUs. I'll show you the different kind of, tools, techniques, groups that we do. But I wanted them to kind of know that like that person has been where I've been. And so we hired people with lived experience, and not just lived experience that were individuals in recovery and long-term recovery, but also people with correctional experience, which was really interesting. So you bring together a staff that works currently in corrections, so CSD, CSWs, together with some staff of BCCs that are now our new BHNs that have lived experience. So they're like, what, you guys are drug addicts? And they're like, yeah, we're in recovery. You guys have been in here? Yeah, we've been institutionalized. And having to bring them together and make a community out of that. So it was kind of a fun trainings as we've done them. One of the first things we did was have the BCC staff, or all of our staff, undergo all the corrections trainings. I want to say Paul and I have gone to 5 corrections trainings at this point, security trainings. As Paul kind of did a really good idea earlier of like what you do in a Code 66, we've learned that over and over again. But at each institution we open up, one of the first things we do is we do a full security training, because they all believe, and I say this and I try not to laugh, but they all believe they're super unique. Like, our institution is unique with its security training. We go, okay. So we do a security training, but then we also educate our staff on parole and temporary absence permits, as well as the SPIN assessment, which is the assessment that helps recognize where somebody would be in security rating. So would they be considered a medium security risk or a maximum? Are they minimum? If they're a minimum, can they apply for a TA? That kind of stuff. Once we do that, we're bringing our two groups together, and we are spending 3 to 4 weeks together learning all about the TC model and what happens in the TLU. And this isn't just us sitting around tables, taking some notes, learning about, dialectical behavioral therapy and cognitive behavioral therapy, but we're learning about the model and then we're role-playing it. We are doing the same thing we're going to ask our members to do in a couple of weeks when we bring them on. They are learning about things like group therapy, and they're role-playing group therapy. They're role-playing peer and self-assessment. They're role-playing diary cards. We're working through the biases that they had as we had those two groups coming together of people in long-term recovery with lived experience, as well as correctional guards. And we're dropping the barriers that happened between those two groups as we're kind of doing more and more groups together, more and more kind of things that are on the schedule that we just taught them all about. And so we spent 4 weeks together having a lot of fun, and doing a lot of training. It was actually really interesting at this point. Like, I remember in one of our staff trainings, we had Miss Fiona Lavoie come in. And Miss Fiona Lavoie is the ADM of corrections, so a very high corrections individual in Alberta. And she was doing a tour of, I think it was Fort Saskatchewan at the time. And so she popped in to see the training, how it is, because we'd been giving her updates on how we were doing in corrections and how the TLUs were operating. But she hadn't actually seen how one of the trainings were going. So she's like, I'll come spend an hour with you guys. And as she came in, I think we were role-playing group therapy, if I'm not mistaken. And so we had all these, pockets of groups, individuals, and it's, our staff and CSD staff all intermingled. We're all in plain clothes. Nobody's got uniforms on. But we're laughing. Some people are crying. There's emotional connectiveness. Like there's a lot of kind of leaning in, active listening. And she's standing at the back and she's got this real quizzical look on her face. And I look over because I'm like, oh gosh, I'm not sure what that quizzical look looks like. Is she angry? Is she upset? And I said, Fiona, you look like you have a question. Can I answer something for you? And she's like, how many of these are my staff, Elizabeth? And I'm like, I look around and I do a quick count, and I think in that room currently there was 22 of them that were her staff, and I think 13 were our staff. And so I gave her that, and I said, most of them are your staff. Why? And I thought she should have known who her staff were, but I'll get past that one. I said, why? And she said, because they look so happy. My staff generally aren't happy at work. They're on guard. They're barriered up. They are uniformed. They are in that role of security. And she's like, it looks like they're enjoying their job. And, I fast forward a couple months later to another conversation with Fiona, and she said, they were in the middle of doing a survey with all the staff that had worked in the TLU, and we're working currently in the TLU about quality of life. Because she said, there's something that you guys are doing that is causing less sick calls, less time off, less needing to go on leave. And she's like, I don't have to cover your unit as much with offering overtime and stuff. And your staff are even willing to do the overtime in other units, and again, they seem happy. And so they were doing this survey because they need to study these things. They can't just be like, yeah, we're doing some great work, come on in and hang out with us. So she was doing a study on it to be able to prove it. But it was really remarkable about that sense, because what that taught me is we had done community. We had brought community together, and the CSD and CSW that were working there had bought into that sense of community. This is a really important slide, and this talks about the 5 kind of major components of what we need to make sure happens in a TLU. So, the first one is belonging. So when we think of the average person that's incarcerated that struggles with substance use disorder, there's a lot of isolation. There's a lot of kind of criminal addictive thinking. There's some distorted thinking. There's probably some low self-image based on what they've been involved with. And there's some kind of messaging as, I don't belong. I have to do this by myself. I can't tell people what's going on. But there's often that real kind of isolated individual. As Paul talked about earlier, people in corrections, they're always on that safety, like, what do I have to watch out for? What's the next thing that's going to happen? And so for our unit, a big piece of this is helping them understand that sense of belonging. We do everything as a community. If I'm on a unit for the day, I'm a community member, which means, I'm engaged in the groups. I'm sitting out on that comfortable furniture, having conversations. I'm having coffee with guys. We're talking. I'm a community member. I'm also a rational authority, kind of, if I say something goes, it goes kind of stuff, but I'm a community member. But we really want to install that idea of belonging. And so people come in and they see, other members, that's what we call them. We don't call them inmates, but other members, and they're talking about emotions. And they kind of look and they're like, is that a plant? How'd you guys make that guy open up? And then, they start opening up themselves, or they start feeling like they can start dealing with the stuff that's been sitting in here for a long time. As Paul talked about, high ACEs scores. We talk about that stuff in the TLU. We do a lot of things at group so that they understand, these are my people, I fit in here. So belonging is a huge piece of what we do. And we want them to see the staff as belonging to their community, the CSD as belonging to their community. Social learning is another big one, and social learning is just that idea of, peers supporting peers and them teaching each other. I love it when a TLU is running like it should, and our staff, they get to kind of sit back and enjoy it a little bit. They're not just crisis management, they're not just putting out fires, they're therapeutically helping individuals as well as doing case management, and watching as the senior members are kind of modeling and mentoring healthy new behaviors to the junior members. Everything, like I said, is done as a community. They give each other feedback. They do what are called push-ups and pull-ups, which help reinforce kind of healthy behavior, or, when somebody's not in healthy behavior, they also give feedback on it. Responsible agency is just that idea of unlearning that criminal addictive thinking, or CAT thinking, as it's called. Unlearning some of the distorted thinking, unlearning some of those neural pathways in the brain that say addiction is the only way I can do something, or criminal activity is what I need to do to survive. Unlearning that and learning about what it's like to be a normative person in a society. And I understand we're still in a correctional center, it's not quite normative, but at the same time, they get up at a certain time, they eat 3 meals a day, they're going to group, they have jobs on the TLU, they have responsibilities, they are part of it, and they have hope that they can kind of take on more and be even more part of the community. It's very similar to kind of like what you and I all do in a daily basis. We get up on time, we eat 3 meals a day, we go to our jobs, we have enjoyment. I hope you have enjoyment in your job, and we have that responsibility. We live responsibly on a daily basis. And so they learn that. But one of the reasons, as Paul talked about, that high dose long-term treatment, one of the reasons we are as, high dose and long-term is because we need the time to teach them that. We need to repeat things time after time sometimes. Like I joke about, I think I said that 48 times so far to that one person, and then they finally get it. But we also know that, these are neural pathways that are pretty firmly entrenched, and it's going to take a while to be able to kind of relearn that healthy behavior. Narrative redevelopment is number 4. Narrative redevelopment is that idea of learning that they matter, learning that they can change the story in their brain instead of it being, about, and you'll read some testimonials coming up, but instead of it being about, I'm a criminal, my family doesn't want me around, my nation has asked me to leave, I don't belong anywhere, and the only thing I can do is engage in criminal activity and use drugs. Instead of that being their narrative, they get a chance to be able to kind of get to a place where they believe I have a future, I have hope. I'm looking at my BHN over there that had significant criminal activity in their past, and now they have a job, they have, they tell me about their life, they're engaged in, instead of criminal activity, they're involved in recovery activities. They do things that fill them with joy. They are, working on a new exercise program, whatever it may be. But they get to change that narrative in their brain and be able to have that hope, have that belief. As we've seen that increase in the ARC scores, part of that is because of the narrative redevelopment of that concept of I'm reconnecting to my culture, I'm reconnecting to who I am, I'm understanding kind of what I want to do with my future, I have hope. That's pretty exciting. And of course, hand in hand with it, as we've already seen, the development of recovery capital is number 5. So all of those, key components are really important when we are designing and when we're making sure that we're doing a treatment program that has a TC environment in it to be able to support our members of our TLU. There's a lot on the screen. I'm not going to go through it all, but these are another 14, what we call the 14 components, and this talks about the important pieces of a TC environment. You need to have a separate unit in the jail. You can't have these guys going back to general population at the end of the night. That's not going to work. And so our unit is separate. We have, we have separate gym time, we have separate yard time, we have separate rec time, our meal time, everything is separate. If we're going to chapel, it's separate. When we have cultural events, we have it separate from the rest of the jails, as an example. Community environment, community activities are hugely important. As we talk about community as method, everything is community. And so if somebody comes to me because they're looking to manipulate me, Elizabeth, I want a specific answer, I'm going to first ask them, have you talked to your community? Have you talked to your senior members on the unit? What do they say? Have you brought this up in group yet? Because, we really truly believe that, by themselves, they, part of their own old addictive behavior is that, those rigid defense systems, is the manipulation, triangulation, but with community, the community will support them. Work as therapy is a really important one. They all have jobs. Again, they all have jobs on the unit. And, if you ever get a chance to come in and tour one of our TLUs, you'll see the job board. And it's busy. These guys are busy. And they, I joke, but I think our units are the cleanest units in any jail because they are constantly sweeping, mopping, wiping things down. They have pride in their ownership of living in the TLU. And they have pride in the fact that they get to, this is their home now. And of course, as Paul talked about that planned duration of treatment, we need long-term time and, the emotional growth training, all huge stuff. This is, again, I really got to make these slides simpler. I'm sorry about that. So I'm going to do this one verbally. This is the pathway if an inmate wanted to come into a TLU. And I'm going to try to make this as simple as possible. Paul and I do a lot of what we call kind of advertising in the different institutions. What that means is we talk a lot. And so we go and, we talk to the directors of the institution, we talk to all the CSWs, we talk to the CSDs, we do tons of education to the people that are working kind of with the inmates. So that's the first piece. But then we put up some posters which talk about the TLUs, nothing super exciting there. But we go through our security training so that they allow us to do what are called tier talks. And tier talks are just that. As you can imagine, as people that have been inside a correctional institution in the past, there are tiered cells. And so we stand there and they all kind of stand outside their tier or they come down to a certain area and we talk about the TLUs and we want to incentivize it. We want to make them, want to come because, change is scary. Coming to and doing addiction treatment in jail is scary. When we say, hey, it wouldn't be really much of an incentive when we'd say, as Marshall Smith used to say, it's the place that you do treatment 12 hours a day, and often there's snot bubbled like crying that happens there. We don't tell them that. But we tell them about that it's a separate unit. We tell them about the safety that happens there. We tell them that we're a no-nonsense unit, and so that's why we've only had one Code 66 in the whole time we're open, because we just don't have politics that happen on our units. We tell them about things like when they come onto the units, they get their TLU clothes, which means for each phase of that they're in, they get a different color sweatshirt. And so, the purples are the orientation, green, the lovely Kelly green is phase 2, and phase 3 is baby blue. But they get to wear sweatshirts and t-shirts. Again, if you guys have been in institutions, institutional clothes are horrible. You wear jumpsuits all the time. And they're jumpsuits that, 99 other people have worn. Most of the clothes that we're giving them are new. And so they're getting new clothes. We're treating them with humanizing them even in just that idea. They have comfortable furniture. The thing that's probably the best incentive, though, is once a month we do a community meal. And what we mean by that is we bring in food from the outside. If the unit has been working together as a community, as they have, really working together, they do a vote once a month and we bring in something that they want. They don't usually, ask for high-class food. They're asking for things like, one time they wanted Costco hot dogs. That was fun for a big group of 20, just saying. They like pizza. They really like Chinese food. And so once a month we do a big celebration meal. And again, as a community member, if I'm there that day, I'm eating with them. We're sitting down as a family, we're eating together. But it's an incentive to come in. And so the first thing we do is we try to incentivize the concept of coming into the TLU with these tier talks, with these posters, with all the education. If somebody then kind of goes, yeah, I've got enough time on my sentence and I would really like to do that, they put in what's called an RFI, which is a request for interview with the SCSW. They fill out a very simple form with the CSW that gets emailed to us, and then we request a lengthy interview time with them. So we spend about an hour with them on the phone doing about an 8-page interview that looks at everything from ERD date, to making sure they've got enough time, to literacy levels, to drug history, to mental health history, to medications that they're taking, any medical issues, because we want to be able to get a most fulsome picture of this individual that's coming in as possible. And it's also just starting to build a relationship with them, talking to them. Often people don't spend an hour talking to an inmate and talking and connecting with them. Once that assessment is done by an RSG staff or a BCC staff, it gets sent to Paul and myself. And so Paul and myself we still review every assessment that comes in, and we approve them. And so for the majority of them, we do approve. Like, I want to say probably our approval rate is about 90%.
Yeah, 90 plus.
90 plus. He's feeling, feeling good today. So 90 plus, because we don't want to set up barriers for people. We don't want to say, oh, because you have a mental health disorder that you can't come in. We believe, that a lot of the work that we're doing within the TLU, the groups that we're doing, the communities method, being able to be part of a responsible agency is going to help their mental health as well. Once we've approved it, we send it to the security specific to the institution, and they have to be able to approve it. Their approval rating is lower. It's corrections. They have to look for things like keep separates, or if somebody's gotten to a fight with somebody in the past, or somebody slept with somebody's boyfriend in the past and they were on PC units because of it. They have to look at all of the little things, and so sometimes they say, hey, we can't send them to Lethbridge, but you could probably go Red Deer kind of stuff, because we're really trying to get these people into care. Once they have been approved by us and security, we're bringing them in. And so they get transported to the institution, and once they're at the institution, they have to undergo a body scan, a clothing exchange, a drug test, just to make sure that our unit is safe. We don't want chemicals coming into our unit. We don't want somebody to bring something in and have the safety of our unit blown up. And so we're doing that. In the assessment process, I'll actually say to somebody, hey, I'm going to tell you, if you get approved here, you've got to do a drug test. I don't care if you're using now. In fact, I imagine you are. You struggle with substance use disorder and you're in a correctional facility, so you have no coping mechanisms. But if you are, get off it now so you can pass your drug test. Because if you get caught with a positive urine, you're going to get an institutional charge and they won't let you come in, which amazes me. Like, you have a positive drug test, you can't come into a substance use treatment center? Anyways, totally different topic. But we tell them that right up front. So they come in, they have their clothing exchange, they have their body scan, they do their urine test, and then they're coming onto the unit. Again, that concept of the community, a community member will meet them right away. They get their new clothes, they go change into their TLU clothes, they get shown into their cell or to their house, as we call it. Often somebody's made their bed for them, because they know they were coming. Again, it's just those little things to try to make somebody feel secure and safe. The senior member would walk them around and introduce them to people. So more of a simplified version of that slide, but still long, I apologize. In each of the TLUs, we have a phase system. And so with the phases, everybody comes in and does an orientation phase. Orientation phase usually is around 3 to 4 weeks, depending on the person. And that one is laying all of the groundwork for what the TLU is, what our rules and regulations are, what, all of those 14 components and 5 components are, making sure they have a really good understanding of what we're doing. They have to do a bunch of work on this. This isn't just read a manual and kind of get a check mark beside your name. They go through multiple groups, they read through it, they put their own ideas down on what these things mean to them, and then they have to have everybody in the community. Before you move from phase to phase, you need everybody in the community to sign off that you're ready to move to the next phase. And if they don't believe you're ready to move to the next phase, they won't sign it and you have more work to do. And so the phases, as I said, orientation, primary, community building, and then aftercare phase. The majority of the work happens in that primary phase. That's when we're doing the case management. That's when we're really assessing them. That's when we're doing all of their kind of therapeutic process, working through the old beliefs. We're helping them see their shame. We're talking about their powerlessness and unmanageability. If they're open to doing step work, they might be doing some step work. They might be doing codependency work, so much stuff. We individualize it to each individual person. This is just an example when we talk about high dose treatment. This is a Monday to Friday schedule for them. They do programming actually 7 days a week. I just couldn't fit it all on one screen, if I'm perfectly honest. So this, I think, if I'm not mistaken, is red deers. They all look very similar because we want fidelity between, but dependent on the institution is different times for rec, different times for meals, different times for outdoor time kind of stuff. So it's going to vary a little bit, but ultimately they're going to be doing a similar thing. So if I look at, say, Wednesday as an example, they're up, lights on, 7 a.m. They've got morning medication. They do, every unit does a smudge first thing in the morning. And this is him telling me that I've got to speed it up because I'm running out of time. So they do a smudge every morning. We want a lot of our members are Indigenous, and so we want them to reconnect to some of their culture. They then have a morning meeting, which sets the tone of the unit. It's all positive. It's super fun. Morning meetings come my favorite that we do. They have lunch tray served. It's always very early. And then they do unit clean, diary cards, and it looks like they've got some exercise in the yard. And then it is peer and self-assessment. They've got a formal count, they've got member interaction, and then they've got a dinner tray, unit cleaned, evening community meeting, and then they're out having some exercise, and then there's a community story, and then some homework, smudging, wrapping their day up. Busy day. We don't give them tons of time to kind of just be off in their brains doing and getting off track. We want to keep them busy for the time that we have them. Again, some pictures of what our TLUs can look like. The one with the flower carpet is actually our female TLU. That was on opening day. If you went there now, we do a lot of art therapy there, so the walls are very colorful with different pictures, different things they've done, different sayings that they put up. We do a lot of movement work with them as well. So right underneath that, there's actually this little kind of theater. I call it a theater, but it's a flat area. They do yoga down there. In the middle picture is actually in Lethbridge, where we have a cultural center, and so we're able to do more Indigenous work with the IPC, which is the Indigenous Program Coordinator. And the far one is what Calgary actually looked like prior to us opening. And so as you can see, it's a pretty barren looking, it's a minimum security unit. No, it doesn't actually have doors, but it's just like that was their unit. Pretty boring, some trays, some of those horrible tables and chairs, and that's it. This slide is treatment process. This is how we help them move through the phases. In every phase, there is specific goals that they meet, behavioral goals, and assignments to help support that. I'm not going to go through each of those because it's a lot of work to talk about treatment phase, but just an idea again of like, this isn't them just kind of sitting around being airy-fairy talking about feelings. We're getting them working, looking at making significant behavioral changes while they're on our unit, and looking then also within phase 3 about like, what is it I want to do? Occupational, like being able to get them into whatever trade program we can or educational process that we can so that they can start thinking about like, what do I want my life to look like now that I'm not an enforcer or a drug dealer? Therapeutic modalities, nothing special here. There's no real secret sauce when it comes to this. We do, of course, trauma-informed care, a lot of DBT, CBT, MI, mutual support meetings, narrative therapy, and psychodynamic therapy. Groups and meetings, as I've already talked about, they're really crucial in what we do, and crucial because of that concept of like community as method. We do very little one-on-ones, and a one-on-one would be, you know, a BHN going through an assignment with somebody, but we don't kind of come into an office, lie on a couch, and tell me about your childhood kind of situations. And of course, you know, the reason that we do the groups and the meetings is to create safety. And so these are just some of the meeting responsibilities that we would have posted in all of our TLUs. Case management. Okay, as I said earlier, the two big things that we're doing in a TLU, one is therapy and the other one's case management. We start case management on day one when somebody comes in, starting to get to know the individual, assessing what their deficits or their social determinants of health, what's missing from those areas, so we can start our best at trying to set them up with that warm handoff or somewhere to live or understanding how to get to a navigation center or getting them into a treatment process post-treatment or getting them sober living, whatever it might look like, getting reconnected to family. We do all of that throughout this process. And so Case management's happening between the CSW and the BCC staff, because the CSW is also doing case management with them. We have a monthly case management meeting where we're reviewing the ideas and what we've got going on, what's the plan, we're adding new things to it, we're inviting stakeholders to the meeting, so it might be parole officers, mums, dads, husbands, wives, elders coming to the meetings digitally to be able to kind of say, well, how about this, adding it to case management, or I can help with this. Because we really, again, we want to be able to have everybody leave there with a significant plan so that we can hopefully break the cycle of, chronic substance use disorder and recidivism. Okay, that's a testimonial. It's a beautiful testimonial, if I'm really honest. That's why I put it up there. This is Adrian. Adrian, I think, is 35 years old. He's had multiple incarcerations. He's got 2 little girls, a wife, and right before he was incarcerated this time, he was actually going to school trying to become, I think it was something with a commerce degree. Relapsed and started engaging in crime again. Believed that that was all his life could be. Came into the TLU and he has hope again. He's breaking that cycle. He's understanding why he kind of keeps going back to substance use disorder and criminality. This talks about the idea of him having hope and hopefully being able to be that dad for his daughters again. So our approach to case management, as I said, there's very distinct the CSW has a very specific role and the BCC staff has a very specific role, and we come together and develop the strongest plan possible. The CSW is doing assessments like the SPIN, as I was saying earlier, to see if somebody could apply for TAs and paroles. They're looking at helping kind of do treatment applications, where the good part about our staff is the majority of them are in long-term recovery, which means they've got good contacts in the community. And so where a CSD might not be able to kind of get an earlier access to a treatment center because, Ryan knows somebody at the Dream Center, we might be able to get that person a bed upon releasing and have them picked up. So just being able to really not only have our separate roles, but coming together and working together for the common goal here. Already talked a little bit about the transition service model, which is having our staff go in and work in remands and kind of develop those relationships with inmates working in remand to kind of be able to kind of look at case management for them, doing our best job for a warm handoff there, assessing, screening, and then trying to make referrals as necessary. This is a slide actually one of my colleagues in corrections gave me, because this is something that they talk about as one of the biggest gaps, is that continuity of care. And so, when I read this because it made a lot of sense to me. Of course, people leaving, if they don't have support, if they're not getting right into treatment, if they're not getting right into sober living or have access to income or even know where they're going to get their next meal, chances are they're going to reoffend. And so our job is to, not just do the warm handoff, but it is also to do continuity of care. So part of the ROSC model and part of RSG, what we've done is trying to develop out that continuity of care, the continuum of care. And so we've got Lakeview Recovery as an example. And Lakeview Recovery is a therapeutic community. It is a 75 men's treatment center, again, phased model, long-term approach, TC, work as therapy, community as method, all those good things that we do in the TLU as well. But it is out in the lovely Gun, Alberta. And so they can actually put the stuff into practice that they've learned in the TLU, and it's that good stepping point before they're out in community again. And it is beautiful. Come on, look at those pictures, for goodness sakes. It's called Lakeview because it overlooks a lake, for goodness sakes. And, coming from a treatment or from a jail, that's a pretty wonderful thing. There's also, as Paul said, there's 11 of these slated to be opened in Alberta. And so, making sure somebody has good quality access to the next level of care coming out of the TLU is hugely important in that continuum of care. If somebody's not going to a continuum of care within a TC model, we have Bolin Health. Bolin Health, the primary, what it does is recovery coaches. So the recovery coaches are trained with the Recovery Coaching Academy, and then they are set to work in places like Bolin Health. And these are people in recovery that they're not counselors, they're not therapists, they are just that, recovery coaches. And they're supporting somebody coming out of care. They know what it's like to walk into the first AA meeting or NA meeting. They know what it's like to go to a food bank because they've done it themselves. And they motivate people to keep them in recovery and be able to talk to them sometimes on a weekly or daily basis, depending on what somebody needs. Additionally, Bolin offers aftercare. So there's the weekly sessions with your recovery coach, there's the aftercare, and then there's a monthly educational sessions on things like anxiety, stress management, popular topic, relationships and early recovery, all that kind of good stuff. And so they offer a bunch of kind of post-care for people if they're not going into a TC, or it might happen for after the TC. But really trying to kind of grab people coming out of the when they're so vulnerable. As we heard Paul's statistics of, mortality rates go up so high for people coming out of jails, we want to be able to capture them and continue to offer them that support. These are another couple of testimonials. This is from Shania. As you can see, I love the difference between the male and the females. The males are like typed up and they're very specific. The women, they've got like beautiful borders. They're writing it, handwriting, and I think there's even some flowers and hearts on them. This is Shania. Shania was one of our original members that came into Fort Saskatchewan. She's been with us since opening day. So I think she's at close to 9 months at this point. And she, again, talks about hope. Talks about when Shania originally came in, she was so quiet because of her shame. Like, she couldn't look people in the eye. She couldn't talk in a group, and now she is a senior member. When we have tours come in, we get Shania to do her the tour because she has such a good voice about what the TLU means and what it does. And so, this is a testimonial from Shania talking about that. The next one is kind of a newer member. This member has only actually been with us now for about 3 weeks. But again, even after a week, she can feel the hope. She can feel like she's belonging. She can feel like, I feel safety on a unit. And it talks about that in here. And she does a really great job of the coloring as well. This is Isaiah. Isaiah is, and I know we're not supposed to have favorites, but he's one of those favorites of mine because he believes that the TLU is trickery, as he says. And so every time I go into the TLU in Lethbridge, he's like, I don't know how you guys do this, Elizabeth, but it's trickery. And I say, what do you mean, Isaiah? And he's like, well, when I first came in here, I said I was never going to talk in group. And he goes, and then I talked in group. And then I was never going to tell that thing. And then I told that thing. And then, I was never going to stay here for like over 2 months. And now I've been here for 6 months. And I never was going to go to treatment after incarceration, and now I'm going to go to treatment past incarceration. And he calls it trickery because he can't figure out, how, we made him make these decisions for his health, but he's like, it's trickery, you guys. And so that's going to be part of the TLU solution in the future, or our model, the TLUs, it's trickery, from Isaiah. And again, Patrick, another really heartfelt kind of testimonial just about the hope that the TLU is offering him back in his life. If you'd like to actually read any of them, you're welcome to come up and actually be able to see them on the screen, on the smaller screen later on, so you can get the actual full kind of piece of it. I'll turn it back over to Paul for a quick kind of closing, and then there's just a couple more pictures.
Yeah, so the key points we wanted to make today is that at least 70% of people who are incarcerated have a substance use disorder, and it's most likely severe. So this is really literally and figuratively a captive audience. The most effective way of reducing criminal recidivism and likely medical recidivism associated with this population is to treat substance use disorders. The evidence tells us that. What is a therapeutic living unit? Think high-dose, long-term treatment model. The ideal time in treatment is 9 to 12 months. Therapeutic effect is not seen at less than 4 months. So it's ideally 9 to 12 months. Case management, and when I say warm handoff, what I'm talking about is filling the gap. That people can't leave an intensive treatment center and have the expectation that there'll be a bus ticket and you have to get up to, west of Edmonton. There has to be somebody at the door to go step to step to step. Time is required to address all the social determinants of health. People who are incarcerated had a lack of exposure to social determinants of health. Many are missing, and therefore it requires a long time, a year, to develop and expose people to those social determinants of health to achieve better outcomes. And the focus again is social reintegration. Treatment without social reintegration is really wasted time. The objective is to address those gaps, assess, find out where the gaps are, and create novel interventions to ensure that the continuum of care is continuous. One last picture. So on the right-hand side, that's down in Lethbridge, and I'm not sure what day that is, but it's a celebration going on with the Indigenous Program Coordinator who's organizing the celebration. It's a one-year anniversary of Lethbridge and Red Deer. And on the left-hand side, that's Robert May on the right, who's the director at Lethbridge Correctional Centre, and Marshall Smith on the left, who's really the framer, the architect of the Alberta model. So thank you very much, and I think it's probably appropriate to just have people come up if they have questions and ask questions, and so other people feel free to continue on with their day. Thank you very much.